breathing simulation. If you are at 80 centimeter or 120 centimeter, even surgical mask is even I mean, at 80 centimeter, if you are in normal breathing, is enough a surgical mask. If you have deep breathing, you need FP2 and surgical. At 120 centimeter, surgical is enough. So just to tell you that for your maneuver, FP2 and surgical mask. And this is what we did. This is our experience, no problem.
So do you have any preference between pressure control ventilation or volume control ventilation based on plateau pressure or driving pressure?
We used, because we are more used pressure controlled.
Yes.
Personally, I don't think there is a major, but we use more pressure control.
Yeah,
yes,
we too. If the plateau pressure is higher than 30, we try to use pressure control in all of patients.
We try to keep the plateau pressure. But as I told you, we have seen not many patients with so good compliance. Most were with phenotype, what we call phenotype 2 and 3. In this patient, we used more or less, we used the usual rules for protective ventilation. We prone the patient almost 35–40% of the patients. Also because you imagine when we had 60 patients, it was almost impossible to prone all of them because we reached a level like this. So just also from organization. But we use prone because some people say, Paolo, you did not use prone. No, we use prone. The problem is that sometimes there were some technical reasons. So
it's possible to prone 30 patients.
So we had to balance everything. But anyway, we proned. Now we are analyzing the data. In some patients, of course, we found good results. In other less. On average, I think we found a little bit less as compared to conventional RDS, for sure. Most of cases, we had an increase in PCO2, not due to the ventilation, because we adapted. So suggesting that it was mainly a redistribution of perfusion. Now we have a CT scan, as I told you, in non-invasive respiratory support, supine and prone. Probably should, and we did also CT perfusion and redistribution perfusion. However, we used, and in some patients was really very, very effective. So, but we use prone position, nitric oxide. This is another issue that we hope to publish, even if we have to check all our recordings now, because we had a protocol. We used in almost 30% of patients. Again, we had only 4 machines, so we could not use nitric oxide to everyone because we have 4 machines. So, and we use nitric oxide for a long period of time. But we had some patients that we used for a long period of time and they went very well. So I think I'm not saying that anything is solving the problem, but it's not true in my opinion, say, oh, nitric oxide don't use. No, we use nitric oxide in some patients for a long period of time necessary. We bought time and it was good. So I think the nitric oxide, prone position, we use recruitment, so everything, I mean, was good. So I don't think that anything is magic, but I don't think that something is wrong. So we were open to even ECMO, as I told you. We use also ECMO. And now in these last 2 weeks, we are trying to do something to look at the impossible, as I say. We received patients from other centers in these last 10 days after 1 month mechanical ventilation, okay? Because now we are one of the last centers that we will close in the future because we are the largest ICU. So we are receiving patients from other hospitals ventilated for a long period of time. Very, very bad, okay? I'm talking about patients which complete you don't recognize the lung and the respiratory muscles of the CT scan. So in this patient, we are trying to use ECMO and see what happens. So the question is possible to cure this patient after so many days of mechanical ventilation? Because this is, I think, is a very important question. Imagine that we have another outbreak, no? And imagine that you have patient treated for a longer period of time somewhere, and then you are a referral center. Should you accept these patients or not? In the conventional RDS, and also I think Carmen can contribute. Usually, no, we don't use ECMO after some many days of mechanical ventilation. But here, I think we are looking at something new. So the issue is to see if here is something different. But it's just to see what happens. And we otherwise the patient would die. So we are looking also at these factors. So long-term effects of mechanical ventilation and possible use of ECMO in these patients.
I have observed a lot of patients with low compliance. And at the beginning, we heard a lot of high compliance, but in my experience, I observed 80% or 70% or more patients with low compliance.
Yes.
In these patients, we are trying to use low tidal volumes like 6, but in patients with near normal, I agree with the name near normal or normal with not high compliance.
Yes.
Do you agree?
Yes, absolutely. When the people say normal compliance is 60. So in anesthesia, unless you are more obese, but more or less is 60. Here the normal is 40, 45. So
okay, yes.
But anyway, yeah, yes.
Oh,
more normal, yes.
Thank God. It's good to see you saying that the compliance is not high, it's normal or near normal. So in patients with a normal or near normal compliance and with hypercapnia, we use a tidal volume a little bit higher, like 8 to decrease PaCO2. Do you agree?
Yes, yes. We in patients with more normal compliance, we used a little bit higher. Even if I can tell you, we had not the problem of CO2. There was in some patients, of course, especially when there was a major progression. But in the initial phase, it was less than we expected. But we used a higher tidal volume, yes. Not too much, but 8, yes. Okay. As we showed that in patients with less RDS or less, there were no difference between 6 to 10, actually, milliliter per kilogram, yes. While we had some, I don't know if you want to discuss later the weaning, that was the issue.
Mm-hmm.
The weaning. Because the weaning was, we started the weaning a little bit later. No, I mean, we tried to have assisted as early as possible, but we were very patient, very calm. Yeah. And then the weaning was required sometimes up and down. So you start weaning and then you have some there and go up and down, up and down. And now we have this also this impression that there is some myositis, and now we are proving that, and some neuromuscular problems. So, and perhaps some activation from the brain, but mainly myositis. So this explains this difficult. So we are very calm in the weaning, going down slow and slow. And I can tell you what we did when we have a weaning of the patient, usually BiPAP or pressure support we use. When the patient deteriorated, we got 2 hypotheses. 3. One is the recruitment, of course, but it was not. The second was overinfection. And eventually, if you like, we can discuss this, overinfection, because it's important. At the beginning, you say, oh, no overinfection. No. Longer you stay, you have almost 25–30%. Now we have a paper with infectivologists. 30% or 40% overinfection after 20 days of implementation. Mainly MRSA, gram-negative, and fungi. That's why we decided to cover with cephalosporin 5th generation since the beginning. So we did not use azithromycin. We use cephalosporin 5 generation. We use the chloroquine. Then you know there is some debate, but we use chloroquine in the ICU. We did not use antiviral. We used delicizumab in patients with inflammation. We use corticosteroids, and we did not use azithromycin. This is more or less our first antibiotic treatment. But just to be back to the or is a overinfection, or the other was the suspect of embolism. So if the patient was deteriorating during weaning, that we never do during RDS, normal RDS, we went to the angio-CT. And in some patients, we found embolism, and then we started thrombolysis, and the patient improved dramatically in 24 hours. So this, I think, is something different for the weaning. So think always about thromboembolism that we never thought in the RDS, in the conventional RDS. Yes, this is. But weaning, we were very, very calm.
Yes.
Very calm. Some people, now I see, and they run behind the weaning. But I think that the weaning has to be very calm, and then you don't need too much tracheostomy, because
Yes.
if you like this, yes, of course some, but no more than 10-15% maximum.
Let me see. Can I show you some two pictures, two CT scan?
Yes.
Posso habilitar aqui, Bruno?
Yes.
Yes, let's go.
These patients do not respond to prone position or recruitment maneuver. When we observe heterogeneous infiltrates,
you have to share. I don't see the slide.
You don't see?
No.
Share screen. Now?
It's coming. Yes.
Yes.
Yes, sir.
Oi, Sérgio, está ok. Aperta agora para aumentar. Aperta apresentar slide. Okay.
Perfect. Yes, you have to click the presentation. Yes.
Okay.
This patient did not respond to recruitment maneuver or prone position. And we have observed that this patient with this CT scan with heterogeneous infiltrates, when we prone these patients, we did not observe a good response. But the other patients with more consolidation, this patient have a better response.
Yes.
Do you think like that?
Yes. All right. So the first one is the sort of with this very good good compliance.
Yes.
And yes, but we sometimes prone if they prone, they respond only as a redistribution of perfusion mainly.
Yes.
But you can imagine that in this lung on the left, 40% of perfusion in this is in white and 40% in the aerated. So very much blood flow there. Yes. On the other, yes, with this CT scan, for sure, I'm almost sure that you respond. But you have another group of patients. You can look carefully at the CT scan that you did. You see the white area here. This is very likely to be atelectasis or part of atelectasis. You have a bronchogram, and that's it. You have perhaps it's difficult to see if you have some pleural effusion, perhaps something, but because you have a little bit, you have some pleural effusion probably on the left and on the right. But there are other patients, because I look at many, and in these white areas, you have a sort of what I call cyst. So white areas that are not cyst, are sort of normally aerated area within a consolidation, okay? And in these patients likely are more consolidated areas. So when you prone, you can have an effect mainly for redistribution of perfusion or no effect. So this is a typical for atelectasis. So this is very similar to RDS.
Yes, very similar.
But you have to also to look at how is the aeration within the white areas, which is I never seen in RDS. Because if it has atelectasis, you see like this, so it's a collapse. If our consolidation like this disease, very dishomogeneous, you have white areas and some black points within the white areas. And these are not bronchi. These are, to me, we measured, it looks like normal aerated tissue within consolidated tissue, which is, because the evolution, I think, is the following. I don't know, but now we are looking carefully. First, you have these gray zones, triangular zone peripheral. Then they become white, so they become, I don't know, probably necrotic. We did some samples from there in autopsy. And then some of them, they are completely destroyed, and you have some area, some cyst within this. And I don't know your experience, but we had also some pneumomediastinum and pneumothorax.
Yes.
Not many, but higher than normal. Not due to mechanical ventilation, but due to the fact that these probably cove areas were completely necrotic and they had necrosis even on the pleural surface. We have a 2 CT scan, terrible, in which you see, and where we have one patient with the chest tube, and then we were able now to close the fistula with a full fistula from the lung to the pleural space. So terrible things that we have never seen.
Yeah.
But I agree, more or less, these are 2 main examples of and why CT scan can be helpful to be optimize mechanical ventilation.
We did not observe pneumothorax, not yet.
Not. I mean, we observed not many, but we observed at least 4, 5, 6 pneumothorax, and yes. 2 were mainly for necrosis of the peripheral areas. One which was with some fistulas that we treated, but required a lot of effort. It's just to take care. I mean, sometimes you can have pneumomediastinum and pneumothorax.
Yes. We did a lot of recruitment maneuver, and maybe one patient with, yes, maybe one, but we did not confirm the pneumothorax because the patient is so critical to go to CT scan. Yes. Take a look at this patient, Paolo. It's a patient that I have in home. Mm-hmm. This patient sitting with 77. Take a look at oxygenation. 77. And when I prone these patients in home, spontaneous breathing 94, 96 in home. What about your experience of prone position spontaneous breathing?
As I told you, we used that. We used it especially in the ward, in infectious disease ward, and when the patient was able to sustain, because of course some patients were not. And we also found the same. So we found that when it was maintained by the patient, they improved. So we used prone position during non-invasive respiratory support. We, in our case, with the helmet and prone. We did a CT scan in 8 patients, supine and prone with the helmet. And we have to analyze the data yet, because you can imagine now we are so busy that we are now to analyze. We have CT perfusion and CT, supine and prone. And however, the first impression is that in prone, there was less aeration. So the total lung volume decreased, but oxygenation improved. So this is just but we have to analyze all the data. Very, very anecdotal actually, just because I've seen 1, 2, 3 CT scans. So it's likely, in my opinion, that in prone position in non-invasive respiratory support, the improvement is mainly due to a redistribution of blood flow. So the blood flow remains in the vertebral zone, and you have a sort of redistribution of these homogeneous densities that are more in the dependent. So you have a reduction in the lung volume with more density in the dependent, but the perfusion remains in the upper. But it's not a real recruitment. This is what we observed by CT scan. But again, this is just the beginning. We have to analyze. This is just looking at the CT scan. So we did not yet analyze all the data of the CT scan. So this is just a word of caution. We used the non-invasive, prone in non-invasive, but I think we have to use it again under careful monitoring and not for a prolonged period of time, because otherwise it's possible that we have a de-recruitment and then we can eventually pay afterwards, not only looking at. And what I learned from this disease is this disconnection from the amount of non-aerated tissue, the white areas, and saturation. because we found that in the white areas that you showed me before, the flow is very low, is less than 5%. So there is no shunt due to the white areas. This is, I think, because there is no hypoxic vasoconstriction, there is hypoxic vasoconstriction in this region or collapse of the capillaries. So to me, there is a disconnection very often from what you see at the CT scan and oxygenation, because the blood flow plays a role. So if I can summarize, this is a pneumonia, is a vascular, I don't want that. But the perfusion play a greater role, than ventilation, to have an interpretation of the gas exchange. And this is probably change our minds. It's very difficult because in RDS, when we have less oxygenation, usually because we have more atelectasis, more densities, blah, blah. Here, even if you have less densities, we have hypoxemic because we have more blood flow completely dysregulated. So that's why it's tricky. So that's why this is a typical example, supine and prone. One believes that, okay, you are subprone and you are better oxygenation, so the lung is better. But this is a tricky disease. Oxygenation is better, but the lung can be worse. I'm not saying that this is bad, but just to say that this is a tricky disease in which we have to interpret the lung imaging and oxygenation a little bit different from conventional, because there is a role of blood perfusion. That's why CT perfusion, I think, in the future, it will become very important. And I would like to redo most of the study on RDS when we will see in the future the conventional RDS, to go back to the perfusion. That was a little bit ignored, except from the San Paolo group by AT. But I think we can be back with very sophisticated CT perfusion techniques in the future. I think that the perfusion was something forgotten in this last year, except for some data, and I see Carmen here, I know Marcelo, everyone, but I think that perfusion has to be reevaluated, for sure in COVID-19, but also in RDS.
Paolo, I don't like the PEEP table for these patients, because the hypoxemia, as you said, is a consequence several times from the perfusion. So in a patient with 100% of oxygen and a near normal compliance, if I adopt the PEEP table, I will use 24 centimeters of water of PEEP. So I can make hyperdistension. So we prefer to use the driving pressure or the oxygenation. Do you think like me? I don't like very much PEEP table in this situation.
We tried not to use PEEP higher than 15. In some patients we used, but for a short period of time, mainly for the right ventricle. Yes, if you use driving pressure, we found that more or less the optimal PEEP was around 12.
Yes, 12 to 14.
Around this level. So in fact, we used in the more severe between 12 to 15, and in less 8 to 12, something like that. But yes, I agree that the driving the PO2 table per se in this case probably has to be a little bit readapted. But to me, again, I would be very patient. So to me, this disease, you know, with RDS, you are always to do something, no? Here, I think one has to be very patient and to wait, and not to be discouraged if you have some up and down. We have patients who went well after 35 days. This is another message that I learned from this. Because at the beginning, we believe, okay, if you don't improve in 10, 15 days, okay, you are done, no? Palliative care, whatever. Then we learned that this is not the case. I mean, we had patients after 35 days mechanical ventilation, hard fight, and they recovered, at least from the ICU, quite well. So I think is a disease that you have never to surrender. That's why we started to do also some ECMO now. So I'm not saying to use ECMO as a first choice. I'm not saying that. But I think it's a disease that requires time. first and after, not hurry. This is my feeling. We had patients that you never spent one coin at the beginning or say, this is dead, it's impossible. And they survived. Other patients died, and I'm not saying that. But I think that one has to fight till the end. While at the beginning, I got the impression that there was the idea that, okay, it's so severe, we cannot do anything, the patient is deteriorating, how long will it take? No, I think it's a disease that we have never, even if you have 85, 82 saturation, one has to fight. And 3 days after, you can get better. So I think it's a disease always to fight till the end, when you have no bullets in your guns. You have to be more killer than COVID-19, I think.
And about nitric oxide, Paolo, there's some studies ongoing in Boston, I think, that are using nitric oxide in super higher doses, like 150, aiming to inhibit the virus replication. Do you believe in
I don't know. I can tell you my experience. We used higher doses than conventional because we say 5, 10, 15, 20. We found the best response was between 10 to 20. On average, we use 15 ppm. We did not use so high levels. So we used, and I can tell you, in some cases we have good response, in other less, but in at least 15% of patients, we use this for a long period of time, very long, and a reasonable percent of patients, this bridge was very helpful to improve, to buy time to improve respiratory function. So I have no experience for such high dosage of nitric oxide, but I have experience for the normal levels. And in my opinion, is something that an intensive care treating COVID-19 should have nitric oxide.
For how long you use?
We used up to, as I tell you, in some cases we use up to 15 days continuously. Yes. Without any problem of withdrawal of like this. And this was also, we have to correlate now with pulmonary artery pressure that we measured by echo. But I did not have got the impression, because most of these patients, they had high intrapulmonary pressure. So it was not strictly correlated with that. It's possible to be correlated with the CT scan. We have to see that. But what I mean is that if you are in trouble, you have 85 saturation, you optimize the PEEP, you did prone position, why not to use nitric oxide? That's my question. Before ECMO. Before ECMO, we always use nitric oxide.
And during recruitment maneuver, are you use PEEP up to 30, 35? What your limit, about your limit?
Personally, I use very similar when I use I go even a little bit, yes, 25, 30. In other cases, 25. It depends on the operator. More or less, we tried, but we did not use differently from more or less what we do in practice. Personally, when I do, I went up to 25, 30, yes. 30 PEEP, and then so the peak higher. But not big difference. I prefer, I always use as Carmen and Marcel, so the progressive PEEP. We don't use anymore the sustained.
Bruno, pode habilitar o microfone da Carmen, para a Carmen falar alguma coisa? If Carmen wants to say something.
You see.
Bruno?
Ok, liberado, professora.
How are you?
Good.
No, I survived from COVID-19. I stayed 1 week intubated and mechanical ventilated with people of 50, driving pressure of 8, FiO2 of 35, and they recover. My muscles stay a little bit fragile, and I'm doing 1 hour a day of physiotherapy, but now I'm in normal.
Yes.
But I recovered 15 days to recover my muscles with 1 hour a day of physiotherapy, but now I'm walking normally.
Yes, but Carmen, but you did not stop.
The recovery is very difficult because of the curare of corticosteroids. I took tocilizumab as well, hydrochloroquine, azithromycin. I took all of these medications, but
Carmen, this was the point that corticosteroid and tocilizumab are a very good combination. I'm not saying that this saved your life, but for sure it played a major role, corticosteroid and tocilizumab. And then you recovered well, also because probably you were not for too long in mechanical ventilation, fortunately.
Yeah.
1 week, 1 week. But most of these patients, they stay 21, 25 days. Now we are receiving patients after 35 days mechanical ventilation. This is the issue. So you were recovered well because you stayed, fortunately, a short period of time, but because you did corticosteroids and tocilizumab. This is, we have all our data from the infectious disease. Those patients with the combination is much better than single. Very, very good. So they gave you the best therapy pharmacological at the moment that we have.
One thing that we are doing at the university and the Albert Einstein, we are dosing interleukin 6 because if it's high, as it was in my case and the other case, we have a doctor in our ICU that the interleukin 6 is very high. He is on dialysis, prisma, mechanical ventilation. He has a very severe ARDS, and if you dose the interleukin 6 and it's high, tocilizumab is we are using, and we are having good results in these cases, in this more severe case. And you don't know why some people develop a very severe, the dimmer very high, multiple organ failure, and interleukin 6 very, very high.
Yes, this is this. We measure in all patients. We have a protocol with infectivologists on interleukin 6 and others, and we also perform the BAL. We have all the pathology. Now we just met 3 days ago. We have the BLL, so we measure all the cellularity and CD4, CD8 in the BLL during the course of the disease and inflammation, and then we will compare with CT scan and outcome and mechanics. You absolutely agree. In fact, also we are giving more preferentially tocilizumab in patients with higher inflammatory response. Yes. And usually we give the first day tocilizumab, and the second we start corticosteroid 1 day after tocilizumab in order not to combine both. But I absolutely agree with you. And there are not all patients, they have such high response. So then we have to see if it is good, if it is bad. For example, troponin, we measured. In our patient, it was not so high as reported by others. While the dimer was higher in patients who had, of course, worse outcome. So I think we have to understand more also about this. But I fully agree with you that if interleukin 6 is high, and usually also ferritin is high, ferritin also.
Ferritin, yes, as well.
These patients are absolutely candidates for corticosteroid and tocilizumab. Yes.
And the anticoagulation is essential. I'm taking rivaroxaban, Xarelto, 10 milligrams for 1 month after the discharge. And I think the anticoagulation is fundamental for these cases.
Fundamental, Carmen. And as I told you, our story was that we started 1 week after the Lombardia, but there were no much news. And then we learned that some patients changed our view. Was this patient who died suddenly after 2 days, and we said, what's going on now? We never had a pulmonary embolism like that, so this is strange, and that's changed the view. And we continue also 1 month after anticoagulation. That's why I think it's a disease that should be treated outside the hospital. But I don't know in Brazil. In Italy, there were some difficulties in the population medicine. And I think that these patients should be more aggressively treated at home with coagulation, not too much, of course, more protected, but coagulation, and in my opinion, to start some corticosteroids at home when you have some first signs, and then to follow after. That's why I think it's a disease that is not only intensive care. It is mainly out of the hospital and out of the intensive care. But this is when I say that this disease should change the mentality of our governors, of our politicians, of our health system organizers. Because it's
yes, and the respiratory physiotherapy after the intubation is very important, because I'm doing the power breaths every day, Voldine and all the kinesiotherapy. You have to breathe deeply and hold for 10 seconds and then exhale. And after I'm walking 2 kilometers in my building downstairs, and know the saturation after 2 kilometers at 96-97% of saturation. But I'm doing a lot of respiratory exercises, and 1 month after discharge, I will do another CT scan and pulmonary function, complete pulmonary function test to see. But I'm not desaturating after exercise, but I'm doing a lot of respiratory physiotherapy. I think it's essential to improve your respiratory function and to keep, because in the CT scan, I had a lot of little atelectasis at the base, and I'm trying to keep my lung with a very good function, but I'm doing a lot of respiratory exercise.
But this is, I'm very happy that Carmen, unfortunately, on your experience, but you
my own experience. With
unfortunately, but,
it's very important to have your own experience, because
it's better not to have, but anyway, but this is exactly what we observed, and so it's a long time. But you are also a physician. You know what to do. You are well. So I'm also thinking that this, how to organize all this kind of stuff, in terms of follow-up, physiotherapy, monitoring, CT scans. In fact, you have seen probably the lung, they have some alteration. As I told you, we have seen also patients from more severe and less. And so this means that the healthcare system has to be organized to monitor and to treat this patient even after out of the hospital.
Yes.
Before and after. And this is something that I am not sure that everyone has clear in mind, because this is something has an impact in healthcare organization.
Yes, and it's possible if you plan a physiotherapy with your physiotherapist, you can recover your pulmonary function, but you have to do a lot of exercise, understand what's happened, and it's very important to measure your saturation before and after exercise. And if you are desaturated, you have to do more respiratory exercise, because you can recover your lung. And another thing that I'd like to say, because we have more than 6,000 deaths in Brazil, and this pulmonary compromise of the disease is very quick. For example, after 12 hours I was intubated, and I start to feel a lot of fatigue, very exhausting. And then we can see a lot of patients that start this respiratory compromise of the disease, but they stay at home. They have to be at a hospital, and we have to monitor this case very, very close, because it's very quick, the respiratory deterioration, and you have to do a lot of things, non-invasive and mechanical ventilation, because a lot of patients are dying because I think they stay at home, or even the doctors or the physicians, don't pay attention that they are deteriorating. It's very quick, this deterioration. You have to be very quick and pay attention, because otherwise you lose the patient.
And in fact, that's why we organized in the hospital this area in infectious disease as also 2 big rooms, very big rooms, where we collected all these patients, and they were continuously under monitoring of, in our case, the team of anesthesiology. We recruited all anesthesiology from operating room. We closed almost all the operating room except for emergency. So there was a big task force of people continuously monitoring, exactly to do what you say, to try at least in the hospital. As I say, if the non-invasive was not effective, to improve within 10 hours, almost we try to intubate patients. The problem at home is very important, and in fact the use of saturimeter at home. This is another healthcare problem, because all these patients should be monitored with saturimeter. Some colleagues of us that were treated by calling, they were very worried, of course, and they do exactly what you did, some exercise at home, and you see if you are desaturating. If you are desaturating, that we asked to be admitted to the hospital.
You have to measure at rest and during exercise, because sometimes you have 94 of saturation at rest, but if you do a little exercise, if you walk a little, we desaturate a lot. So you have to measure during exercise.
Saturation drops so fast.
So yes, so saturimeter and effort test is very, very important for a correct monitoring. In fact, our colleagues, I had the honor, the privilege to follow them by phone. They were at home, and fortunately they went well. We treated with corticosteroids and enoxaparin at home, and they did always, every day they did this test, and they sent me the image of the saturimeter, and we discussed what's going on. This is absolutely, but you know, Carmen, to do something like that means that we have to change the mentality of the healthcare system, because you need another saturimeter. You have to change the mentality of the medical assistant on the territory. Very important, also from a political point of view. We hope that our governors will take some experience from this. Also to improve, this is good also for COPD, for other diseases that you know better than me. But I think that this is not only disease for the ICU, it's not only a disease for the hospital, it's a disease that has to be, can be defeated, of course, by a vaccination like this, but mainly by the control on the territory. What I say is mainly a population disease. It's not like a patient, or is a patient-oriented, but it's mainly population disease. And as a population has to be controlled on the territory, exactly as you said. But to do that, you need monitoring on the territory, physicians going to the patients, track the patients who are positive. So you need a huge effort.
And nowadays you can buy a saturimeter with a low cost.
No, yes, this is true. But I wanted to
buy a lot of saturimeters.
I can tell you my experience. I wanted to buy one just to be. You never know. Especially at the beginning, it was a very hard, and I did not find, because on Amazon it took 1 month to come. But anyway, in the pharmacy there was almost one. So at least in Italy, where I am, it was not easy to get one. But I say, if I get some symptoms, I ask to be admitted in the hospital. I go to my sub-intensive care. No, but I'm just joking. But it was not so easy to find the saturimeter in Italy, even if you're on the internet.
No, here in Brazil it's very easy to buy a saturimeter nowadays.
Nowadays, probably now is
very high cost, but nowadays you can buy a saturimeter 100 reais.
But you see, this
means
a very high price. But Carmen, this means that in the future, even physician on the territory, apart from COVID-19, they should be equipped by a saturimeter. They should be equipped, in my opinion, of a simple lung ultrasound. So what I mean is that this experience should be very important, even from the territory medicine. The importance of physiotherapy in many diseases also on the territory. So I think there is something that probably was forgotten or was not considered so important. So this, I think, is a stimulus for the future.
And one thing that I noticed from myself is after intubation, my diaphragm is not working very well. So I did a lot of exercise with the physiotherapist, and then we recover my diaphragm. But after intubation, when I was in supine, I feel a lot of dyspnea. I have to sit, and we discovered that my diaphragm is not. We did ultrasound, and my diaphragm is not working very well. Then we recovered, and it's very important to do a lot of exercise.
Regarding this, now we were able to got the approval, and we got the samples from the lung, diaphragm, respiratory muscles, so we had some samples from people who died, unfortunately. And I hope we will get at the end at least 15 of these very specific samples, very near to the death. So very near to the death. So it's not autopsy, it's special techniques. And we found a large amount of myositis. So in the diaphragm and in the intercostal, now we see in the popliteum, lymphocyte or this within the sarcoma of the muscles. So it's possible that some alteration that we are observing in terms of neuromuscular might be due to a sort of myositis, which can open another field if this is confirmed. This is an idea also for our cardiologists to actually to maintain some dexamethasone, for example, for a little bit longer period of time. But this is just an idea. But we found some myositis in the respiratory muscles of patients who unfortunately died by COVID-19. So this is something that has to be considered. So it's possible that some of this problem in the weaning may be also due to irritation of the muscles.
The respiratory muscles.
Yes,
but
yes.
I think we can recover this if you do the right exercise and if you pay attention to correct this.
Yes, yes.
I remember that I changed my decubitus, prone, lateral, after the weaning, and I do a lot of respiratory exercise, and with the time I improved a lot.
Yes,
But
yes.
I changed the decubitus, do a lot of the deep breathings, hold the breath, exhale, and with time, the respiratory muscles respond.
Yes.
And recovered. But
Yes.
you have to pay attention of that and do the right,
Yes,
right exercise.
That's why as you see in my some very, very quick slides, I focus on the role of physiotherapy. I think that even more than in other pathologies, we always work very well with our physiotherapists. They are one of the few intensive care in Italy, I think, in which we have a continuous respiratory physiotherapist. So for a long period, all the day. So it's a very aggressive physiotherapy, and we are very proud of this. But in this disease, I think is even more important. Is fundamental, like mechanical ventilation. Is even mechanical ventilation at the beginning. Physiotherapy, respiratory physiotherapy, is essential in the weaning and in the after discharge.
It's so good to see. Okay, Karen. Go ahead, Karen.
No, it's important to continue the physiotherapy after discharge a lot to recover all your muscles and all your functions, and to recover well. People, I think people is using less than they can the rehabilitation program.
Emma, you need a follow-up program. to do this.
Yes.
You did by, I mean, because you are in a special condition, Carmen. But,
Yeah. No,
for the normal healthcare system, I mean, first of all, you know what you do, even so you are not an example. You are very special.
I was very well treated.
You know, you are very well treated, and you know
Yeah,
exactly what you do. So, you are
very,
doing
very
yourself.
well.
But for the common people, this means that you need a follow-up, multidisciplinary follow-up.
Yes, yes.
And this is
I'm telling this because I think we have to improve, and
yes.
you can take care as well as they took care of me. Every people we can when take a better care than they are having.
Yes.
It's possible to. If you do the right things, I think we can recover more than people are recovering around the world.
Otherwise, this can become...
Did you see New York? I was very when I saw the New York mortality, a place that is very developed.
Yes, yes.
And all the conditions, economic conditions, and a lot of people died in New York.
Yes. And this is
I don't know what happened there, but
huge.
I think
and then the question is that if you don't do that, the risk is that we can have a major load on the healthcare system in the future.
Yeah.
Because if you recover well, okay. But if you don't recover well, you can have a chronic lung disease or with fibrosis, I don't know, whatever. And so this may be a problem. So that's why it's very important to anticipate this. So, and this I think is a message from this webinar that we are doing all together for all people hearing this, that this is very, very important. Many people focus only on the phenotypes, mechanical ventilation, like this is very important, therapy like this, but this final stage is very, very important. And you have to be organized for that.
Mm-hmm, mm-hmm. Yeah.
I like a lot functional exercises in ICU, Paolo. In Brazil, we do a lot proprioceptive neuromuscular facilitation, functional exercise into the ICU, like you drink water and to walk and make trunk control. It's possible to do this into the ICU. Physiotherapy in Brazil is so good, and we try to do something different, not only to sit and to going up, but to do functional exercise. It's so important to the recovery of this patient. And I'm so happy with Carmen. Carmen was my teacher, Paolo. I love Carmen. I was
she was so good that the people who cured her were so good to save her.
Brazil is happy now.
Yes,
Paolo,
yes.
they told me that when I was intubated, a lot of people cried in the ICU.
Yeah, I cried.
Yes, but with
they didn't expect that I was intubated, because 35 years that every day I see patients with pulmonary infection, respiratory infection. I never had a pneumonia or a severe infection, only flu. But suddenly I had a very severe, the COVID-19 attacked me. So a lot of people cried, but they took care of me very, very well.
Very, I can tell you something.
Fortunately.
Carmen called me.
When you were intubated, I got immediately the message from Brazil.
Oh, yeah.
So I say, wow.
My God, what happened? And I took care. I took a lot of care, but I didn't know how I got that, because all the people that stayed with me that week, no one got COVID-19. I don't know if I saw a symptomatic patient that was closed, because I didn't take care of a known COVID patient. I used masks during the office. I don't know, but It's important to, other message, you have to take a lot of care because we don't know if you are going to have a very severe or you are going to be asymptomatic. It's important to take care not to get this disease. I'm taking a lot of care, a lot. I wash my hands 20 times a day, a lot of gel alcoholic and all the things. And they don't know if I have EGG positive now, 2 PCRs negative because I'm falling, but they don't know if you are immune or if you can get again.
Did you do the test or not?
Yeah, I did. My PCR was positive 21 days after was positive, but now I have 2 negatives.
Yes, no, but
14 days ago, 14 days ago, and 1 week ago, I have 2 negative PCR, and the IgG is positive.
It's positive. So you are immunized now, or at least you have the IgG, but you should be partially
the IgG is positive. They think I'm immunized, but they don't know if you can get again or not.
No, but they say
a lot of discussion about it.
Yeah, there's a lot of discussion, I know, but they say that even if one, I hope not, but is in a mild. So if one is IgG, is better. I mean, I'm negative, but we'll see.
Yeah,
we hope for vaccination.
The vaccination is coming. I think in more 10 months or 1 year, the vaccination will be ready.
We hope so.
We hope so.
And Paolo and Carmen, what do you think about closed loop ventilation in these patients? Makes difference to use PEV or NAVA or smart care?
I can tell you our experience was that we were so many patients that we tried to do simple things, complex but simple things, and we did not use these kind of systems. That could be, but NAVA I think is very difficult. You have to use another catheter.
Yes, I think so.
It's impossible. Some automatic, I don't know, but we had not experience on that. But I don't think this can make a big difference.
Yeah, we are using only pressure support ventilation.
Yes, exactly. We use pressure support. So I think it has to be treated with simple, complex, but simple. So prone, whatever, even, but not, there is no space for very exotic techniques, I think. So,
I think because it makes no difference.
A lot of people in the ICUs, and it's very difficult to use these special kinds of mechanical ventilation, but smart care and public you can use if you want.
It's
but NAVA only in special cases that you are having difficulty in weaning or a lot of asynchrony or but only in special cases.
And when we go to extubation, have an Australian study that called mask over tube technique. So immediately after extubation, they put a mask with a filter to avoid environment contamination. It's a new proposal, and I think this is a good proposal. What do you think about?
I can say about, as I told you about our experience, usually in our patients when extubated, we try to extubate in a negative chamber when possible, but anyway, we used or CPAP by helmet or some positive pressure or even high flow just to support and for 1-2 days with some steps during the day. And yes, we used some assistance, especially in those patients after long period of mechanical ventilation. So it was not a study, but our physiotherapy, physiotherapists, we always did that. So I think it's a reasonable. I don't know if one method is better than the other, but some assistance in terms of pressure, I think if well tolerated is good.
Mm-hmm.
Carmen?
I think it's very important to intubate to no invasive or high flow, or you have to take care. But for example, when I was intubated, I needed 3 periods of no invasive because I was very
Weak.
no, it's very difficult to ventilate without any assistance.
Mm-hmm.
And I think you have to check your respiratory muscles if they are function well. And I think we are intubated in the Hospital das Clínicas and in Einstein to no invasive, and the results are very good.
In this term, I think if you can add something, as I showed in our protocol, it's very important to have a good test before extubation. Even here, one has to be in a hurry. So I would not recommend never to extubate early or something like that. To extubate when you are almost sure that extubation is good.
Yes, exactly.
But not to do extubation early. This, I think, is very important. Again, as for weaning, to be very patient. So to do only something when is supposed to be the right time, but not to anticipate or to be in a hurry.
Reintubation is so complicated in these patients.
Sure.
Because if you are reintubated is not good. So in my opinion, that's why I was so proud that we had almost no reintubation. Because I think this is perhaps it's better to spend 2 days more, but not to reintubate it, to be earlier and then to intubate. Because you lose more time, it's more difficult. So that was my experience, and I think is shared with you.
Mm-hmm. Perfect.
I'm so happy to hear about physiotherapy, because I know that it's so important and so good to see that 2 of the most important physicians in the world agree with the physiotherapy in this kind of ICU. So, Carmen, se eu pudesse, eu estaria aí fazendo fisioterapia em você, que seria o meu sonho aí te ajudar a te reabilitar. Queria poder passar. Vamos marcar.
Eu lembro muito daqueles seus slides com aqueles pacientes neurológicos, você fazendo a fisioterapia e eles se reabilitando, que eu falei, vou fazer todos esses exercícios que vai dar certo.
Vou marcar aí. Só você marcar, fala, vem cá que Sergio que eu vou. Marca aí. Sei que você já tem fisioterapeuta, mas posso ajudar.
Eles me fizeram subir 5 andares aqui do prédio, eu consegui, quase morri, mas consegui. Antes eu subia 3, já ficava cansada. Agora eu subi
ótimo.
5 andares. Eu falei, meu Deus do céu, acho que eu vou ficar melhor do que eu estava antes.
Estão fazendo um ótimo trabalho, pelo jeito.
Intensivão aqui.
Isso. Carmen, obrigado demais por ter participado aí. Só enriqueceu sua experiência aí, foi sensacional. O Brasil ficou triste e agora o Brasil está feliz. Hein? A terapia intensiva brasileira não é a mesma sem você sabe disso, né?
Não, e é legal mostrar que a gente pode se recuperar, né? Mesmo ficando entubado e ventilado mecanicamente. Se você fizer tudo direitinho e seguir um programa de reabilitação, você pode voltar a ficar normal. Isso que eu acho bem legal. Achei bem legal isso.
Brazil is happy now, Paolo, because Carmen is back.
Absolutely. I was so happy for that.
Yeah, everybody. You want to say something more, Paolo? Carmen?
No, it's okay.
It's okay.
No, I think we had a very lovely discussion, and was very nice also because Carmen could present her own experience. We have seen COVID-19 from in the eyes, but from outside. She seen COVID-19 inside the COVID-19. So it was a very nice experience also for me to have this discussion, and we hope that everything will be better, but I think that we have to be extremely keep attention, because it's always possible to have a second wave. That's what we fear in Italy. And so I think we are going better, but we have to be prepared for something worse in the future. And I'm also very worried about the winter season. Is different from you, but from next summer, winter season. And
we are very, because everyone is at home, so social isolation, and they don't know what will happen when all these people go to the street again. Né?
Exactly.
That's, because one day we have to go out home.
Yes.
And they don't know exactly how to do that and what will happen. So it, we have to plan, the world have to plan all this reconstruction and all this resocialization of the.
Yes.
But I think the internet will be in our lives more than before.
I think yes, as we are demonstrating now. Unfortunately, because I would prefer to come to Brazil and have good dinners and good drinks with you, but much better than by computer. But anyway, I can tell you something in 1 month, because tomorrow we stop a little bit the lockdown, and we will see in 25 days what happens in Italy. Hopefully well, but we will see.
Yeah, we have to see. We have to see what to do with this virus. It's very violent. It's very different. It's like a virus from labs or from genetic transformation.
Who knows? But they say not. But so, what we know is that it's a terrible disease.
Yes,
Much
and we have to take. We have to take care, but the humans have to think and to do a plan to reconstruction and to fight this this disease. But I think the world will be very different after all that.
I think yes.
There are a lot of patience.
For some years we will not be back again, because also psychologically, can you imagine, wherever this disease will be out, how can you think about meetings, social events? From psychological point of view, will be very, very difficult. Just to mention, tomorrow we have almost the end of the lockdown, or at least they started to decrease the lockdown, and they say, okay, they will open again the cafeteria or like this, but how many people will go there? Because psychologically, tomorrow I have to take the train from Chiavari to Genoa, usually empty. I don't know tomorrow. I will leave very, very early in order to find many people. So for sure, we have, the fight is not at the end.
I have seen a lot of patients, 5, 6 per day in ICU and 4 or 5 at home per day. There are a lot of patients in home with oxygen, and the situation is not good. As you saw, 77% of oxygen saturation at the home.
Oh my God.
Yes. This patient lives in California and don't have health plan in Brazil, so he is afraid to go to the hospital. Yes. Yeah. Okay, Paolo. Okay, Carmen, thank you very much. Paolo, thank you very much, Carmen.
You.
Thank
you. It's
you.
A great honor. It's a great honor. Okay.
It's very, very good to participate and discuss this disease with you.
Participação especial de Carmen.
Professora Carmen.
The survival.
O meu amigo Bruno aí.
Ô, Bruno, e aí, como é que você tá, Bruno?
Ô, lindo. Eu abri todos os retorno da Uma salva de palmas pelo seu retorno. Muito feliz a senhora ter voltado. Tá bom?
Go on, né? And when I opened my eyes, I was at the ICU. Oh my God, I survived it. But I know everything because I work with that. I know that if you need the intubation, mechanical ventilation, you have to do so. It's okay for me to do all these things. And I know that I need it. And I'm very grateful to all the people that took care of me. And no, very, very good to be here in this world a little bit more. It's very good.
Tem mais 50 anos a mais aí, Carmen.
Não, 50 não. I will do 60 years on Tuesday, on Tuesday, 5 of May, next week.
Wow.
60. So I'm in the group of risk. I have hypertension, and the 60 years is that's why I got this coronavirus.
Fazer uma festa à distância.
Yeah, the party will be next year or after 2 years, but that's good, very good to be alive.
Beijo, Carmen.
Beijo. Kiss, Paolo. See
Ciao.
you.
Keep
Ciao,
strong.
Paolo.
Okay?
Tchau, Paulo.
Thank you very much.
Sergio,
Bye bye.
abraço a todos.
Ciao.
Thank you.
Thank you.
Thanks a lot.